heading to the OR himself. He's got to have a hip replacement. For avascular necrosis. Does anybody know what that is? Means the blood supply to his hip. So his hip bone and everything in his hip is dying. So he's going to end up with a hip replacement. He's loving that.
He'll be brand new.
He will. Well, I can't stop him now. He just will not stop. I'm like, okay, slow down. Can't climb them ladders no more. Trying to do roll, guys. Are some of you that went to the OR, I think you got an email from Ms. Fink this morning. She was sending everybody that could not go to clinical. Courtney, you are okay to go. I don't know if she told you that, but you're okay.
I'm sorry, what'd you say?
Courtney, you're okay to go to clinical this week. Did you get an email from Miss? Well, whenever you have clinical this week. Okay, so we had you on the list, but you went earlier, so I think you're okay. Taylor, you're okay. Taylor Allison, you're okay to go.
Okay. We had to get tested anyway, though, right? I mean, I did.
Yes, but the thing of it is you were possibly exposed. So you still have to go 14 days, and you went the 9th that time, or the 12th and 13th, so you're good.
Okay.
You're good to go. Cameron, you're okay. I don't see you yet. I don't know if this is driving y'all crazy, but it's driving me crazy. Jordan, are you and Emily, you should not be together. Are y'all together or no? Jordan.
Sorry, I was muted talking. We're not together.
Okay. All right, how are you feeling?
Fine.
Good. All right, I'm trying to do roll here. Courtney T, are you here?
Yes, ma'am.
Okay. Dana, are you here? Let's see her. Madison, I didn't talk to her. Brian, are you here?
Miss Walker, I made it. It's Madison.
Okay, good. Did you get you some cabbage?
No, but I told my husband to bring some home.
Yes. Best thing you can do. Okay, I don't see Cameron. Cameron, you here? I got you, Garrett. Deanna. I don't see you yet. Chandra.
I'm here.
Okay, good. Erica.
I'm here.
Andrea. Emily Lip. Brian. I got you, Selena. Dana. I've got everybody but Cameron, Emily Baker, Deanna, Andrea, Emily Lip, Brian, and Dana. I got everybody else. Okay.
Cameron's getting on now. She was having some difficulties with her internet.
Okay.
Miss Walker, I'm here.
Emily Baker. Okay.
Yes, ma'am.
All right, guys, this COVID thing is going to be the death of me. Miss Fink has been emailing everybody that had an issue with the OR because the OR was had a cluster. So Catherine Bell,
Yep.
did you go to the OR?
I did.
Okay, so you can't go this week.
Yep.
Madison Murtagh, you can't go either.
Okay, I saw that.
Osmond, you can't go.
Yep, I saw that.
And Emily and Jordan, y'all can't go. So that's the only ones that I have that can't go. I will be sending you guys a email with your assignment on it. Did anybody that I just called, were you able, or have you already done the ACE inhibitor assignment? Have any of you done that one?
Yes, I have.
Jordan has. Okay. Anybody else? I'm trying just not to give you Swift River. I'm trying to give you something else. Jordan, have you only done the ACE inhibitor one?
And I did the one that you sent us for the OR when we didn't have it Thursday,
Okay.
where you
I
had to
had
watch the videos and stuff.
Okay.
I had the ACE inhibitor and then the OR one as well.
Okay. All right, I'll send y'all some stuff. Okay, so that being said, we've got a lot of work to do this morning. So I'm gonna go ahead and put my, I'm gonna go ahead and record, start the recording. How are those recordings doing? Coming?
They help a lot.
Okay, good. Yeah, I can't believe they won't listen to me twice. Okay, I think I'm not going to, since we've got so much to cover today, I'm not going to be going through the review like I normally do. Okay, maybe we can do that at the end. So I think this is where we started, or we stopped the other time. So I want to go ahead and start with the nursing interventions of the first stage of labor. I've sort of just did the interventions for you, but these are not always the interventions that are going to be done based on certain things that are going on with your patient. So during the first stage, remember there's 3 different phases of the first stage. So sometimes they sort of change, i.e. vital signs might need to be monitored more frequently as the patient progresses through labor. Fetal monitoring maybe need to be continuous, and we'll talk more about that as we get into each one of them. But one of the things that you're going to do, obviously, is you're going to check vital signs. It's very, very important. Do you remember what preeclampsia is? You guys just talked about that.
Yeah, that's with the blood pressure
Yes.
is really, really high.
Yes.
And we want to
And-
avoid seizures.
Absolutely. Absolutely. That is our whole goal in anybody that is preeclamptic, to make sure that they don't seize. Because once they have a seizure, they are now eclamptic.
Correct. Yeah.
So if I've got a patient who comes in and they've been diagnosed with preeclampsia, I'm going to watch that blood pressure more frequently in every stage of labor. Where, in other words, I'm probably going to have that blood pressure monitor or the blood pressure cuff on them and taking that blood pressure every 15 minutes, because I can't take a chance of that blood pressure jumping up, because I know if that pressure goes up, then the perfusion to my baby is going to be decreased. So you've really got to watch that blood pressure. You still got to do a head to toe assessment on your moms, and you do them just one time a shift, like you do when you're taking care of a med surg patient. There's just things that are a little bit different that I need to make sure that I'm assessing. And that is the fundus. Obviously, every patient that you take care of doesn't have a fundus unless they're in labor. So you know where to find that fundus. It's right below the xiphoid process. And if it measures, do you guys know how to measure? I think you talked about that in Intrapartum as well, is you go to the sensus pubis and you measure to the fundus. It should be in correlation with how many weeks they are. But as they go into labor, and that should be just something that you do at the very beginning of your assessment, is do that measurement. Because once the baby starts dropping, once the baby start getting engaged, that centimeter is going to go down, because the fundus, the baby's dropping, and the fundus is going to, particularly when they get into the pushing stage. So you don't need to do the measurement of the fundus, but just one time. But what we're looking for, does anybody know what SGA is?
Small for gestational age.
Gestational age.
Small for gestational age. So you would expect when you measured that fundus and the patient's dates were 40 weeks, they're measuring 34, because that baby's small. So the measurements are not going to equal up. The same thing, does anybody know what LGA is?
Large for gestational age.
Large for gestational age. Now, who do you see large babies with?
Diabetic moms.
Diabetic moms, absolutely. So you may see them measure 42. My husband's cousin had polyhydramnios, and you talked about that as well. And she had twins, and she measured 54 centimeters at 29 weeks.
Wow.
So do you see the difference? And we know what hydramnios is. That's lots and lots of fluid. And so we've got to make sure that those numbers are matching up, because it could indicate that the baby's small, the baby's large, or we've got too much fluid. So it may need another intervention that needs to be done, particularly if it's a LGA. I need to do an ultrasound and get some measurements of that baby. I also, if it's hydramnios, I've got to get ultrasound to measure the amount of fluid in there. So there's more interventions based on your fundal height that you need to make sure that you assess for. Edema, and you talked about preeclampsia. Edema is majorly important. All pregnant women are going to have some edema in their lower extremities. Okay, but we're talking pitting edema, +4 edema. That's going to be associated with preeclampsia as well. So make sure that you do that. Check for dehydration. Check the perineal area. What if they have active herpes?
They have to have a cesarean, or the baby can't go through birth canal?
Absolutely. Baby cannot come through birth canal. They're going to have to do a C-section. You cannot let that baby be born through the vaginal canal if that mom's got active herpes. Very, very dangerous. And of course, we're going to be looking for fetal heart tones, and we've talked about fetal heart tones. We're going to look at the presentation and the position of the baby. And there are also some lab values we need to make sure that we check for. We've talked a little bit about this, but I think you talked about this in antepartum as well, is that when you go, you always need to make sure that their VDRLs are back and that they do not have any types of STDs. And that's the lab values that we're going, because syphilis is very important. I can't deliver babies vaginal with that either. So there are a lot that we need to make sure that we check on those lab values. Why is that RH factor so important?
We need to give
To
her.
know if you need ROGAM,
If they need to have ROGAM, and what moms need ROGAM?
RH negative moms.
Negative, all negative moms.
Mhm.
Because even though they tell you that this is the daddy, I'm not absolutely 100% sure that this is the daddy.
Yeah.
Okay. So you need to make sure they could have had another booger in the woods somewhere. So they may need, there may be somebody else that's there too. And we just going to not take any chances and make sure that that RH factor is, if they're negative, they're going to get it. We also want to do a UA as soon as they come in. What is one of the most important things that I want to check for when I do that urinalysis?
Protein.
Protein.
For protein, absolutely, absolutely. And we always have got, during this every stage of labor, we've got to see how mom's reacting. We've got to see how she is dealing with the labor pains. And then it's my job to do other things to assist her in being comfortable. And the other thing that you've got to do, you know, we talked about birth plans. I'm not having anything for pain. Well, when a mom gets so upset and can't handle the labor pain, then it's our responsibility to talk to her and do other methods to help her deal with the pain. And we may need to explain to her that pain medicines is an option. Okay. And make sure that they've got a good support system. There are lots and lots of moms, particularly with COVID going on around here, is they don't have that support that they need. We are now letting one person go in with them. So that's, they will at least have someone to take care of them. You know, most of the time without COVID, we're going to depend on the family to assist us in making sure that their labor and delivery is what all they expected, and that my mom and my baby are very, very safe. One of the things that as a nurse during all stages of labor is that we have to be supportive. And we have to give them praise. I don't care if she is hanging from the light fixture. You tell her she's doing a good job. Okay, you give her praise. Let her know that she can do this. Give her reassurance and encouragement, because she doesn't need to hear, you are not doing this right. You need to be very supportive with her. Your responsibility is to make sure that you offer every comfort measures you can to her, whether it's massage or just helping her get cleaned up. One of my pet peeves when a labor patient is when their membranes are ruptured. And keep that pad underneath them dry, because they're going to continue to leak. Do you like laying in a bed of wet fluid? That's very uncomfortable for that mom. It's just an easy fix. Make sure she's dry down there. If she's moist down there, then we're just increasing that risk of infection. And remember, if the membranes are ruptured, the barrier from the outside world is broken. And all that moist down there is just asking for infection to occur. So keep that mom good and clean and dry. We are their advocate. If there's ever an advocate place that we need to be, this is it. We have got to make sure that we help them achieve their goals. The biggest goal that I want you to make sure that you tell them is that we have a healthy baby and a healthy mom. We don't care how we get it. If it's a C-section, so be it. We've got to make sure that they know that we can make this the best experience for them under the circumstances and be that support for them, offer encouragement. If there's family members there, offer them a break. Let them get away for a minute, because it's very hard for someone, a significant other, to watch their wife go through labor and they can't do anything about it. So they may need to step out a minute too. And of course, we want to make sure that we look at their plan of care. What did they expect out of labor? What do they want to happen? And we will do whatever we can to assist them and making sure that it's happening. But if for some reason it doesn't, then we need to tell them why. For instance, what if that baby's having some late decelerations? What if that baby is not responding well? Well, when they make their plan, they don't think about a baby not doing well. They want to make sure they think that, oh, everything's going to be great. My baby's going to respond to everything. But there's some reasons that babies don't respond very well. So we have to make sure that we educate them in every stage of labor. I did put a PowerPoint up, or one of the slides up, that talks about the different cultures. And I think it's later in here. We have got to accept every culture that we take care of. I know sometimes I took care of a Chinese lady one time, and she's not to touch her baby. That was what she told me. I can't touch my baby for 9 days. So there's somebody else that has to take care of that baby for 9 days. So the only time that she can do anything with them is if she chose to breastfeed. Change diapers, she's not to bathe, she's not to do anything. So it's very important that you ask them, what are your beliefs? What do you want? That's part of their plan. But there's so many times that I don't understand everybody's culture. So I have to ask them, tell me what your expectations are. What do you believe in? Because I'll be the one that was bebopping in there and handing the baby to this Chinese lady. And she's like, oh no, I'm not supposed to touch that baby. So we've got to understand what their wishes are and what their beliefs are. We can't disagree with them unless there's something that's going to endanger mama. Okay, everybody mute. Endanger that mama or the baby. And we've got to explain to them why we're doing what we're doing. I know I'm going very quickly, but this is these are interventions, but it's what you'll normally see, but I'm going very quickly. It's pretty much, this is what it is. All right, in the first stage of labor, it is very important that if your mother's membranes are ruptured, you have got to take that temperature every hour. Every hour, okay? Or if that mom has a temp of 99.6, that's another reason. Most of the time, temps every 4 hours, just like with your other vital signs or some of your other vital signs. But you have to understand the importance of, if you have a mom that has ruptured membranes, or if she came into the hospital with a temp higher than 99.6, you're going to take that temperature every hour. And don't you miss an hour. Because within that hour, that mom can start, that temp will start going up. And that is going to be your first indicator that mom may be having some type of infection starting. Okay. What other thing on a monitor, a fetal monitor, would tell you that baby might be getting some type of infection?
Increased heart rate.
Increased heart rate. Absolutely. So those might be the first two things that you see, and then you got to react on them. We can't be waiting around. Well, let's see what next hour is. Well, let's see what's going on here. Let's see. You got to keep moving. And there again, you got to get that blood pressure every hour. And you'll see as the mom progresses through into late active labor and to transition, those vital signs need to be documented and recorded and taken more frequently. So you can see that those things are going to be more frequently. The other thing is that you need to make sure as the patient progress, or anytime you're taking vital signs, you need to put those vital signs on the strip. You need to write every time you take them, put your vital signs on the strip. Write them on there. That's another place that you need to document them. All right, so have you noticed that I put on here auscultate fetal monitoring or fetal heart rate every 30 minutes or every 15 minutes, depending on the risk. During the first stage of labor, mom's going to be up bebopping around. So mom can be off the monitor. She doesn't have to be on the monitor all the time. So it's your responsibility. If that mom wants to walk around for 15 minutes or so, when she comes back, you better get that fetal monitor and see how did that baby respond to her up walking. The other thing is that you've got to assess if they're not on the monitor continuously, then particularly in the latent phase, you still have to put or palpate those contractions and document them every 30 minutes. So yes, she may be sitting up in the chair and we've got her off the monitor, but every 30 minutes, you've got to go in there and you got to assess that fetal heart tones, and you got to assess and palpate that uterine contractions to see what they are. Most of the time, moms during the later part of latent and into active, they're going to be on continuous monitoring. Okay, I don't want that mom to stay in the bed because gravity helps, doesn't it? Gravity helps walking around. Oh, they have mobile monitors, somebody said. Oh, that's cool. That's pretty awesome. I didn't know they had that. Thank you, Maya, for telling me that.
You're welcome. I thought it was pretty cool when I saw it also. They just hook it up like normal and she's able to ambulate around the L&D floor and you can still see the fetal heart rate and everything.
Oh, why didn't I come up with that? I should have invented that. Because I think that is awesome because you still got to palpate them and you still got to check them and keep up with them and make sure that it's okay. But I think that's amazing. Thank you for telling me that. I'm just so excited. Did they have that at Huntersville too?
I didn't see it.
Okay. But that's
yeah, they had that at Huntersville. It was like connected with Bluetooth. So then they could see everything.
Oh my gosh. Isn't that amazing? I'm so excited. Thank y'all for sharing that because I haven't been up to a labor and delivery floor in a long time. So it's giving us more data to know how that baby is responding while the mom's walking. That's awesome. Awesome, awesome, awesome. All right, so I'm not really going to go through every one of these because the interventions are the same. The one thing that is during the active phase, most of the time mom's membranes are ruptured. So we're going to limit the vaginal exams at that point. Remember we talked about the other day, if membranes are ruptured, we don't want to continually check them. So the nurse through her assessment, let's say that mom is in here and she's in active phase the last time I checked her, and she tells me she needs to push. What's the first thing you think you want to do?
Check the perineum.
To check the perineal. Can I do that assessment before? Because their membranes are ruptured. Do I need to make sure that I really limit that time? So I may not be one time that I want to check her yet because I don't really see a lot of changes. So on the fetal monitoring, if she tells me she's got a lot more pressure in her bottom and she feels like she needs to push, what would I see on the monitor?
Wouldn't you see the early D
increased
cells if it's coming
contraction.
down the canal?
Absolutely. Was that Brooklyn? Good job.
Yes, ma'am.
Good. So would that give me another reason to check her? Because remember, we gotta be careful. We don't want to check her if we don't have to. But if she's telling me she's got rectal pressure, and then I see early decelerations that are new to me monitoring her, is that something that I may need to check her for? Because that's going to give me some indication that that baby's head's coming down. Good job, Brooklyn. Good job.
Thank you.
You can see that it does change a little bit, but there's not anything else different except that the vital signs become more frequent and we're assessing the pain during active phase. The contractions are going to get worse. The contractions are going to get stronger. So we're going to have to really, really assist her in helping her deal with the pain that's going on. The other thing that you may need to do is, or that you need to do when a mom, particularly once they start getting into the active phase and they've had an epidural, they may not have the ability to feel that their bladder is full. It is your responsibility to make sure that, Somebody talking? You got to make sure that that bladder is not full. You got to check for bladder distension, because if that bladder is full, can that baby come down the canal? No, it's going to impede him descending down and coming out, because our goal is for him to get his hiney whiny out. So if that bladder is in the way, I've got to make sure that I get that bladder out of the way so he can descend. We are trying to get away from putting Foleys in moms, okay, because of the increased infection. So there's a lot of times that we'll do an in and out. If assess that mom's for bladder distension and it's distended, then I will do an in and out catheter. I'm telling somebody to mute your mic. All right, so remember we talked about when the membranes rupture, we're looking at the time. Remember Taco? Time, amount, color, and odor. All right. Does anybody know what meconium, we talked about this, I think the other day, meconium stained fluid, right?
Is that
so when that mom's membranes rupture and there's meconium stained fluid, that mom always has to be on continuous. So if mom was up bebopping around and her membranes rupture and there's meconium stained fluid that looks like pea soup, that mom now has bought herself the bed. Okay, she needs to be in the bed from now on, because I've got to be able to keep that baby's heart rate monitored 24/7. At this point, usually this is when mom wants her epidural. During the active phase of labor, she wants that epidural. So what we see a lot of times is that mamas, when we get that epidural, their contractions will slow down. So we may need to have, and I've got induction, which I meant augmentation, because remember the difference in induction and augmentation. Augmentation is when she's already started into a pattern, she gets her epidural and she started, then she stopped contracting. So she needs a little push. So we get augmentation there. Anytime the membranes rupture, the first thing that you're going to do is that you're going to check for a prolapse cord. And after you check for that prolapse cord, get that mom back on the monitor and auscultate that fetal monitor and see what's going on with the baby's fetal heart tones, because that baby has had all that fluid in there to go around to help him move around in there. And now that fluid's gone. So it puts him at higher risk because he doesn't have all that fluid to compress the cord. And so then if he presses down the cord, what kind of things on the strip are you going to see? Variables. Absolutely. Are they in any relationship to a contraction?
No.
No.
And what do they look like?
Like U's and V's.
U's and V's. Absolutely. And we'll talk about prolapse cord in just a little bit. Prolapse cord is very dangerous. It's life-threatening situation to that baby. So we'll talk about that in just a little bit on what we need to do. All right, transition. This one, mama loses it. What is the dilatation for transition?
8 to 10.
8 to 10. 8 to 10 centimeters. So mom's going to be on the monitor continuously. I'm going to be checking those vital signs about every 30 to 15 minutes, depending on if they're high risk or low risk. I want to keep that mom on the strip. This is the worst time in labor. Now we're talking about a patient who doesn't have any pain medicine. This is the time where they tell you, I got to push, I got to push, I got to push. And we've got to make sure that what is completely happened before I let mom push.
Complete dilation.
She is completely effaced, which is 10 centimeters and 100% and completely dilated before I let her push. Y'all did listen to me the other day.
Oh, yeah.
Sometimes y'all listen to me. All right. Any questions about what needs to be our interventions that need to be done in the first stage? So what ends the first stage?
The first stage is ended by dilation and effacement.
Right. So she's 10 centimeters and she's 100% effaced. What about the station? Can it still be 0?
Yes.
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 So if it's 0, what is that telling me? When she gets completely dilated, completely effaced, and she's at a 0 station.
We have some time before delivery.
We have some time before the delivery, especially if she's a first-time mom.
Right.
So we've got a little bit of time and we got a little bit of work to do. That's why they call it labor.
Yeah.
Because we've got to get that baby down. That baby is not coming down like I want it to. So what kind of interventions do you think you can do to help that mom get that baby down?
Is it that ball?
Repositioning?
What? I'm sorry.
I said repositioning.
Repositioning, absolutely.
The birthing ball, the
birthing ball, that's going to assist. And what about gravity?
Squatting.
Yeah, squat. If you don't have an epidural, or if you do have an epidural, has anybody seen the squatting bar used?
Yeah, I've seen that before.
So what happens is, even if mom's got an epidural, you can lower the bottom of the bed and there is a bar that you can attach to the actual bed. And she can pull down on that ball to help get that baby to descent. That baby's not coming down good. Now, do babies always come down?
No.
No. So if my mom is been completely dilated for 2 hours and been trying to get that baby down, what do you think might be happening with that baby?
Too big, maybe?
It's too big. Absolutely. And that mom's pelvis may not be able to maneuver itself to get that baby down. And eventually he's going to tell us he doesn't like where he's at. So he's going to start showing us what?
Decrease heart rate.
Decrease what?
Heart rate.
Signs of distress.
Signs of distress, absolutely, which will be what?
The late decelerations.
Our late decelerations. Absolutely.
Heart rate.
And that's going to be how he's going to tell me, I'm not coming out that way. I'm not coming out that way. So there are times that during this time, this second stage, this is where people will think, oh my gosh, I'm completely dilated, I'm completely effaced. It's going to be here before long. There's sometimes that moms push and push and push for 2 and 3 hours, and they still don't get that baby down because the baby is too large to come through their pelvis. Remember, we talked about your pelvis has to be proven to deliver X amount of weight of a baby. So if this baby is too big, he's not going to be able to come out. So we're going to start pushing, right? Second stage, we're going to start pushing. Does anybody know how to tell somebody pushing or assist them in pushing?
Is it like chin down?
Chin down. I usually say like a mad cat. Like they got that chin down and they want to bear down as hard as they can to push that baby. Remember, we talked a little bit, there's an effective way to push and then there's an ineffective way to push. Most of the times, moms, when they're ineffectively, they're going like this, pushing like that. I need mom to hold her breath. I need mom to hold that breath and push down as hard as she can. And I'm sure those of you that have been to labor have and seen vaginal deliverers, how they have you count. So mom, we can count to mom with mom to help her push and get that baby down into the canal. So any questions about when we're after, remember when that baby in the second stage, he has to go through all those cardinal signs or cardinal movements. Remember those? You better.
Yes.
You better remember those. You better know those cardinal movements that baby does when he comes down that canal. So he's doing all this during that second stage of labor. All right, third stage. You're going to talk more and more and more about newborn care in the next unit. But what I wanted to let you know, as soon as that baby's head, and we talked a little bit about this the other day, as soon as that baby's head's out, what are they going to be doing?
Suctioning.
You're going to suction what first?
The nose, and then the mouth.
The nose and then the mouth.
You're going to do the mouth and then the nose.
Nose.
Okay. Yeah. So we want to get all that stuff out of the baby's mouth before they take that deep breath and before that amniotic fluid sucks down into their lungs and then they aspirate it and then we got another issue.
Right.
Okay. So what you're going to see is as soon as that baby's born, they're going to suck the mouth and the nose out and then they're going to check for what?
To make sure the cord is not wrapped around.
Absolutely. They're going to check to make sure that cord is not wrapped around the baby's neck. And what's that called?
Like a nuchal cord?
Nuchal cord. Absolutely. And as soon as that baby comes out, they're going to start drying. Most time moms are, or once the delivery, if mom wants this in her plan. Now, my daughter didn't want to even touch her baby until that was cleaned off. She had a C-section, but she grossed out over blood and all this kind of stuff. So most moms want that baby to go straight to skin to skin. Do you know what I mean by skin to skin?
Yeah, put the baby on top of the mom's chest.
Yes,
like
put the baby
skin on skin, literally.
Yes, because that's going to get the baby what?
Warm.
Warm. Absolutely. You put warm blankets on that baby and you're constantly drying that baby off because we don't want him to be wet.
Right.
And we want him to be on mom and skin. Now, if baby's having difficulty, as soon as he comes out, we're going to put him in the warmer.
Yeah.
Okay. But if the ability of the baby's not struggling or anything, then we want skin to skin. And we're going to do skin to skin. Even if we have to take the baby to the warmer, we're still going to do skin to skin as soon as possible. Okay. So once we get the baby out, now we've got to assist with the delivery of the placenta. What am I looking for to let me know that placenta has detached?
The lengthening of the cord.
The cord starts lengthening.
We got maybe gush of blood.
A gush of blood.
The globular shaped uterus.
Yes, and the uterus starts getting rounded.
Okay.
Okay. And it will take, sometimes it may take 5 minutes and sometimes it may take 30 minutes. But you cannot pull on that placenta until it has detached. When you start pulling on it, then you're going to rip that uterus right out of that mama. And you're going to have a major hemorrhage problem.
Can't you invert, I think, the uterus that way or something? And now
Absolutely.
you hysterectomy?
You can pull it straight out.
Yeah.
So it's very important that you wait to make sure that placenta detaches on its own. Now, in antepartum, did y'all talk about the placenta a little bit? I know that you're going to talk about that in postpartum.
We talked about
what it looks like.
one vein and all that.
Right. And how many in the cord, how many arteries and how many veins?
2 arteries, 1 vein.
2 arteries, 1 vein. Good. And that we're going to actually, once the placenta is delivered, we're going to get cord blood.
Yeah.
We're going to save that. And there's going to be lab values that are going to be taken from that cord. And we are going to the physician will inspect the placenta. There is a mother's side and an infant side. And you have to make sure that they are good and intact and make sure all the blood vessels, because there could be something wrong with the baby or the placenta, could be something wrong with it. So, all right. So we just talked about that. As soon as the placenta is delivered, Pitocin is started. We generally put 20 units of Pitocin in 1,000 cc bag of lactated ringers. Now, every hospital, there's some hospitals that'll put 10 in 500 and some put 20 in 1,000. You've got to follow the policy of wherever you are. That's why I'm not going to be testing you on, because there's different policies, different. I just want you to understand that you have to wait till the placenta is delivered and then Pitocin is started. Why do you think that we're giving that mom Pitocin?
It helps the uterus contract back down to size.
It helps the uterus get down. Does anybody know what that's called? So the uterus started as a pelvic cavity organ. Then it became an abdominal organ. So where do I need it to go back to?
The pelvic cavity.
I need to go back to the pelvic cavity, absolutely. So this Pitocin is going to assist the uterus in starting involution. So it will go back down, start contracting, and it will start going down to where, because remember when the mom first came up into labor, where was her fundus?
By the xiphoid process.
It was way up here. And then when she delivers, where is it going to be?
Down in the pelvis?
Umbilicus.
It's going to be around the umbilical area, isn't it? So the involution has happened, right? But it's going to take about 6 to 8 weeks to get it all the way back down So it's a pelvic cavity, in the pelvic cavity. So we want to make sure, that's why you do fundal checks on moms and postpartum. And I'll let Miss Chandler handle all that. All right, I did put during the 4th stage, guys, you have to stay with that mama to make sure that uterus is firm. You have got to be, and if that uterus is boggy, you are going to stay there and you are going to massage and massage and massage and massage until you get that uterus firm. The Pitocin is going to help, but the massaging, can you teach mom to massage that uterus? Absolutely. You have her, after you've got it good and firm, and you had a hard time getting it firm, then you better stay there and teach her too to how to do that so she can do it. And I put a picture up here to show you how that you need to check for the fundus. If you notice that, and I know that you saw the demonstration from Miss Chandler and you've been in postpartum, but I want you to make sure that you see this hand right here, my left hand. Mm-hmm. Do you see how that hand is holding that uterus over the bladder?
Yeah.
Please put your other hand, please put your hand here when you're assessing a uterus, because if right after delivery, you can push that uterus right out of that vagina. Okay, so you have got to hold this right here to assess that fundus. Do not, because there are times that you can push it right out. So make sure that you do not push that fundus out. All right, so mom stays in the postpartum area for anywhere from 1 to 2 hours, depending on how she responds. If her vital signs are stable, because guys, what just happened? She just had a baby. She lost a lot of fluid. She is at risk for hemorrhaging. So what are going to be the first 2 signs in your vital signs that are going to tell you if something's wrong?
High heart rate and low blood pressure.
High heart rate and low blood pressure. There are times that you need to take that blood pressure every 5 minutes, particularly if your mom is showing signs and she's got a what fundus?
Boggy.
If she's got a boggy fundus, you better make that nursing judgment call to take those vital signs every 5 hours, 5 hours, every 5 minutes, not 15 minutes. You're going to do every 5 minutes. You're going to continue to watch that temperature depending on how long her membranes were ruptured, because if her membranes were ruptured for a long period of time, she's still at risk for having that infection in her uterus. And if the infection is already in the uterus, then it's just going to get worse. You've got to make sure that you check that temperature as well. We're going to be watching for bloody discharge. When you assess the mom, you have, particularly if you're having a boggy fundus, you need to look at the perineal area as well while you're massaging. Because if you see a little trickle of blood coming out while you're massaging that uterus, and you see a little trickle of blood, 9 times out of 10, there's a clot in there. And I got to continue to massage that. Sometimes, that vaginal area is a little bit tender with all that stuff going on down there. You may actually have to open up her labia and pull some of the clots out of her vagina. Okay, so, but you don't want that clot staying in her vagina because that's just asking for infection. So you want to make sure that she's good, that the discharge is not a trickle, that the discharge is starting to slow down a little bit as you massage that fundus. The other thing is that you want to watch for is and this is one thing that students have a really difficult time doing, is knowing when a mom is bleeding too much. So if you just clean this mom up and 15 minutes later, she is totally saturated. She's bled through the pad onto the bed and has a big old circle, this big of blood. That's too much. And you better get on that fundus and you better massage. Okay, because that uterus is not clamping down and she's hemorrhaging. So I think everybody understands the importance of me talking about that fundus. All right, so when you clean the I think I didn't talk about cleaning. Maybe this is this one. You better clean that perineal. See if you can get mom to void right after delivery. See if you can get her to void. Put a pan underneath her when you're cleaning her up and make sure that she is or see if she can actually void. And if she hasn't void, it's very important that you keep up with the time that she voids. Mom needs to be able to pee between 6 and 8 hours after delivery. If she doesn't pee between that time, then a lot of times what I'll do is I'll say, I'm going to have to put that Foley back in, or I'm going to have to put a Foley in, and then that scares the pee out of them and they go pee-pee. So we've got to make sure that that bladder, because a bladder, and I know that Miss Chandler talked to you about this, a bladder can cause increased hemorrhage being full. So we want to keep that bladder empty and make sure that that uterus is calming down and starting to firm up. The other thing that you want to do is inspect the perineal. You know that they may possibly have a episiotomy. Does everybody know what an episiotomy is?
Yes.
Where they actually cut and have to stitch back up the perineal area. So you're going to see a lot of edema down there, and you may actually see a hematoma. So a nursing intervention would be, let's put some ice on it. We need some ice on that perineal area, particularly right after delivery and up to 24 to 48 hours after. All right, so one of the things, when we talk, when your patients had surgery, they're in a post-op area. Well, this mom's going to be in a post-op area too, and she's going to be transferred over to the postpartum unit. There are certain criteria that she has to meet before she's transferred over there. So she's got to have stable vital signs. She's got to have that bleeding under control, a uterus firm. Her bladder is not distended. And if she had an epidural, we have to make sure that she has recovered from any anesthesia that she's had. In other words, she can feel her feet and she can walk on her feet before she can go. That anesthesia has got to be completely worn off before she goes. All right, I integrated some of the things that when we were talking about the first stage of labor, about having that mom ambulate is very important. She can get, we're using birth balls, positioning, water therapy. Sometimes moms can get into a bath. That is, if their membranes are intact. Do not put a mom whose membranes are not intact in the bath. Okay. All right. And that's pretty much. Y'all can read through this. I just like to keep reinforcing things. I did want to show you a picture of things that we can do to help that baby descend. Here's a picture of the birthing ball, and here's a picture of a mom squatting. So I wanted to show you those, to some of the things that we can do. These are just all things you can do position. I say it 25,000 times. And this is when mom's actually pushing. You may get her having lots of help when she's pushing. So we need to make sure that she's pushing effectively. So I put that little picture there. Oh, Lord, I didn't talk about this. All right. I think it is time for a break. I've got 10:56 on mine. So 15 minutes. So we'll come back at 11:14. Babies are going to have respiratory problems. So we got to maintain their respirations. We already talked about what the rate, 36 to 60 is the baby's respiratory rate. That's within normal limits. It's going to be a lot of irregularity there. It's going to be difficult to count sometimes because they have periods of apnea. We don't worry about the periods of apnea unless they're greater than 20 seconds. I'm not going to sit there and wait on that baby to, if he's after 10 seconds or so, I'm going to be rubbing his feet. I'm going to be rubbing his back. I'm going to be stimulating him to get him to breathe. You will see if babies aspirate, which is very, very common. And particularly when we have, and we're going to talk about a precipitous delivery in just a minute. When babies come out, I usually say, excuse my French, but say they come out like a bat out of hell. They come flying out and there's no stopping them. They are at risk sometimes for aspirating, and those are the ones that you're going to see that have the grunting and have respiratory issues. Most of the time, and like I said, it's a respiratory issues. If they have cardiac issue, if it goes into a cardiac issue, then that baby had that cardiac anomaly throughout the whole pregnancy. So respiratory is the big, big thing. APGAR, you're going to talk more about the APGAR scores in the postpartum unit. That's why I haven't gone over that. So that's care of our baby. We talked about that. I wanted to put the vital signs and what's regular. One of the things that you're going to see with a baby's heart rate is it's going to be irregular, and you may actually hear a murmur. Do you know what a murmur sounds like? With a newborn, it sounds like lub, sh, dub, lub, sh, dub. And you have to go back to fetal circulation and why you hear murmurs with newborns. All of those 4 different things have to shut at one time. And sometimes their ductus arteriosus does not shut. It's prolonged and it doesn't shut immediately. So that's why you're going to hear a murmur in that baby right when they're delivered. Do we get really upset about that murmur? No. Okay. Most of the time when you hear a murmur on a patient, we get a little upset. On a newborn, I have to give them time to adjust to the world, the outside world, because all 4 of those things have to shut at one time. And sometimes it takes a long time to get them shut. So we are going to watch it, and we're going to let our physician know, the pediatrician know, that we murmur, but we're not something that we're going to get all bent out of shape about. Unless they start, the pulse rate starts going up or the pulse rate starts going down. The other thing I want to tell you is in a newborn or in a pediatric patient newborn, we do not wait till that baby has a no heart rate before we give CPR. If that baby's heart rate is below, some books say 80, some books say 100, we start giving compressions if that heart rate's low. So in an adult, we wait till there's no heartbeat before we start initiating CPR. With a newborn, you don't. You start if it's between 8, if it's less than 100. I've always been taught less than 100. You start with compressions. But so I did read somewhere that they said 80 now. you know, we've got, it is, and that means that the respiratory system has now involved the cardiac system. So we do not wait. So one of the, and we talked about the cords, how many arteries, how many veins. One of the things that you can tell when I've got the sole creases on the heel, does anybody know what I mean by the creases on the heel? What does that tell me about that baby?
That the baby is term.
The baby is term, absolutely. So preterm babies, babies that are born before 37 weeks, may not have creases on the bottom of their feet. And that's going to tell me if they're term or not. That's going to be another indication through my assessment. So always assess the bottom of their feet as well. The other thing that is vital during this day and time is that you have to identify the newborn by putting on bracelets and the security system before that baby leaves that mama. Okay, so if I had to take this baby to the NICU, I need to identify that baby prior to taking it away from that mama's room. So you put 2 bracelets on, you put one on the wrist, one on the ankle, and then you put the ankle security system on the other ankle. So that is very, very important that you make sure that you identify that baby prior to it going out of the room. We definitely want mom to be able to bond with baby, but if something's going on with that baby, we have to make sure that we know whose baby that is before we take them out, and bonding may not happen right immediately if something's wrong with the baby. We know we talked about skin color a little bit. Remember, this baby's not going to look like the Gerber baby. It's going to have bluish tint on his feet and his hands. Does anybody know what that's called?
Cyanosis?
Acrocyanosis, absolutely. Our acrocyanosis. Are we worried about the blueness of the hands and the feet?
No.
No.
We're not worried about that because we understand through fetal circulation that that is a normal finding, that that baby's hands and feet are going to be blue. It's going to take it away. It's going to shunt all the oxygenated blood to where it needs it. The brain, the lungs, the heart, the feet, and the hands are not important right now. So don't freak out if your baby's got blue hands and blue feet. Sometimes it takes several hours for that to correct itself. So that's a very good educational thing you need to talk to mom and dad about, because they want to know why their baby's hands and feet are blue. So use that as a good teaching time. All right, so I used the term just a minute ago, precipitous delivery. And what happens with the precipitous delivery is we don't have time. I don't know if I've told you the story about a girl I went to nursing school with. She called or the physician called and said she was coming over, got to the floor. She delivered her first baby in 28 minutes of getting on the floor. The second baby, I'm getting ready to leave. I'd been working 3 to 11 and I was getting ready to leave, and all the nurses were with their patient. So I answer the phone and the ER says, I've got so-and-so in the ER. I said, bring her up. So I'm running around going, okay, we got to get the warmer ready. We got to get this together. And everybody's going, you are crazy. You're crazy. Why are you? You hadn't even assessed this patient. I said, I had her the first time. I know. Got in here, had that baby in 19 minutes. The third baby, she walks in the door. They called me and said she was coming. Did the same thing, started screaming out orders. Everybody was laughing at me. It was like, you're just overreacting. That baby came out. I was in the room and I called the physician and I kept saying to her, get your clothes off, get your clothes off, get your clothes off. I got to get you in the bed. I got to get you in the bed. She was there 14 minutes and I only got one glove on to deliver that baby. So that's a precipitous. It just happens very, very quickly. In every hospital, there is a precipitous pack. and it has the necessary things that we need to assist if a mom comes in and just is ready to have this baby very, very quickly. One of the biggest things that I can do if I look at that perineal and I see that head coming out is I try to scrub as much as I can or get it clean, and I try to put on sterile gloves. And I'm praying to Jesus that I've got a bulb syringe. So it just comes so quickly. We can support the mom, but I'm telling you, that's the way to go. No pain, they just slide right out. And sometimes we see that with multi-its, that moms that are come in and deliver very quickly. You just do the best you can. One of the things that I learned as a labor and delivery nurse is that I never break down that bed before I know the physician's there. Because if I break down the bed and I have her in stirrups and she's getting ready to have that baby, those are little slimy creatures. And they come flying out sometimes like you wouldn't believe. And even though I played ball all my life and I was a shortstop, I'm not taking a chance on catching that booger. So I want to keep the bed not broken down. So if she comes out or the baby comes out, at least it's on a soft surface. The bed can catch her or him and make sure that he's safe if he comes out that quickly. So that's one of the things that I've learned. So nothing's different. The baby's going to descent like he's supposed to. It's just that a precipitous delivery means that they are delivering very, very quickly. They got there very quick. I was considered having a precipitous delivery with my second one because when I got to the hospital, I was only there for 45 minutes. So that's not giving the nurses and time to prepare for what's going on. It was a nice delivery because it went quickly, but you got to remember that we may not have everything that we need readily available. The biggest things is if you can clean that perineal off and put sterile gloves on and have a bulb syringe. Okay.
Miss Walker, I have 2 questions. I'm sorry.
You're
so
fine.
with this fast labor, I know it's probably going to vary between moms, but do you see a lot of tearing since the baby's coming so fast?
Yes, you do. Okay. The biggest thing that a nurse can do, because it's beyond my scope to cut an episiotomy, is while she's delivering, put your hand and put a lot of pressure on the perineal area. So
okay.
Pressure there, that will decrease the tearing. Yes, good question.
I forgot my second one, so it's okay.
Well, if you think of it, holler at me.
I will.
All right, so let's talk about pain control. One of the things that we are seeing in labor and delivery is getting all the moms pain control. But we also have to realize that every medication that we give this mom is going to cross the placental barrier. So that baby is going to get whatever we give mom. Okay. If it's given IV. Okay. Because we're not going to mess around with giving mom PO pills. Everything needs to be given IV. So I've made a list. Well, of course, we're going to make sure that mom's okay and that she's been instructed on the risk and everything and the benefits of getting this pain medication that we're getting. And we have to make sure that she's not allergic to anything and that anything is not been or everything is not contraindicated. For instance, when I mean contraindicated, if my mom's coming in and she's coming very, very quickly, or she's moving very, very quickly, like when I had Dylan, he went very, very quickly. I was begging for pain medicine. Well, I was so close if they couldn't give me anything because of what the medication would do to the baby. So what do you think when you're giving narcotics, because we're giving narcotics in labor and delivery, what do you think I'm so worried about in the timing of giving a narcotic to a mother in the delivery of the baby?
Fetal respiratory.
respiratory depression. So if I give mom some medication, I was begging. I was 8 centimeters. I was begging. I need something for pain. 10 minutes later, I have a baby. I couldn't get anything because they knew if they gave me that narcotic, my baby would come out and he would not be breathing. So that's one of the things that when I say no contraindications means that how close are you? And there's times that I have to tell moms, I can't give you anything right now because you're too close to delivery. So these are other things that I want to make sure. For instance, if my baby's having late decelerations, he's already telling me that he's not liking his environment. I'm not going to give him any narcotics. I'm not going to give moms any narcotics. If his heart rate is either elevated or low, I'm not going to give him. I've got to make sure that he has reassuring signs on his fetal monitor and that he can accept this narcotic that we're getting ready to give him. So variability, remember variability is so important. When you look at the fetal monitoring strip, you've got to know that's his sign of saying, I like everything that's going on. Is he moving good? Is he having some exhales? Is he term? I can't give a mom that's preterm any pain medication or any narcotics because that baby's not going to be able to metabolize it. It's not going to be able to do. So moms that are preterm sometimes do not get anything but an epidural. Okay, I'm just talking about IV stuff now. Now, there are times that we also give for, I'm going to have to shut my door because here comes the guy working on my bathroom, sorry. Y'all hear a bunch of knocking, I'm getting my bathroom remodeled. All right, so when opioids are given, we usually give them early in labor. And we want the mom to relax because if she relaxes, then she's going to be more apt to dilate that cervix and progress through her labor. There's sometimes that we give sedatives. And the reason why we give sedatives is, let's say if a mom's in the early stages of labor and she's been up for 2 days, I need her to sleep. So a lot of times what we give is Benadryl because Benadryl is safe to give during pregnancy. So Benadryl sometimes knocks moms out so they can actually get some rest before the big birthday party. So you are going to see things like that given as well. The first thing I want to tell you is that you can mark out that Nubain. Even though your book talks about it, I've talked to a physician that's an OB physician and asked him, what meds do they give now? And he said, they're no longer given Nubain, even though your book says that. So if they're not giving it, then I'm not going to test you on it. They're not giving as much Demerol either. So one of the most common things that you're going to be seeing is Stadol and fentanyl. Okay, that's the 2 most common medications that they're giving for pain in a laboring patient. I have written out, you can give Stadol IM or IV, but I can tell you in labor and delivery, you're going to give it IV. You can give 1 to 2 milligrams every 4 hours. It is very, very rapid. The bad thing about Stadol, it doesn't last long, and it's not going to totally get rid of the pain. It's going to knock the edge off. They're not going to be pain-free. They're still going to hurt in between the contractions, but they're still, they're going to get some relief, but some of the big things that's good with Stadol is that they're able to rest in between the contractions. That is something that's very vital. Remember, we talked about the resting tone in between the contractions. If I can get mama's uterus to relax and I can get her to relax, then she's going to be ready for the next contraction, because she's probably only going to have about a minute and a half to get ready for that next one. But at least I got a minute and a half of her relaxing. So Stadol is the most common one that we're using now. Not a lot of side effects, except it makes mama drowsy. Well, I want mama to be a little drowsy before, so she can rest in between those contractions. But the biggest thing that worries me is that if I give this to mama, I'm going to give it to baby. And that baby, if he's born, is going to have respiratory depression. So that's why we have to be careful when we administer this. Where is this mom in labor? Is it going to be enough time that that baby can excrete it and mom can excrete it before that baby's born? So we want to make sure that we have that amount of time. Demerol is, like I said, this was one of the most common things that we used for years and years and years, but we're trying to get away from that because it's not easily absorbed and metabolized like Stadol is in pregnant moms. It hangs around a little bit longer and it increases that baby's risk of having respiratory depression if I can't get that Demerol out. Those of you that have been in labor, what in the experience in clinical, what have you seen them use?
I saw Stadol.
Fentanyl.
Yeah. So that seems to work a whole lot better. And baby, there again, baby's could possibly have respiratory depression, but it doesn't seem to last as long and we can get it out of the baby. All right, so we know that respiratory depression is what is going to happen to my baby if I give them Demerol or Stadol. It also can cause bronchoconstriction. And we don't need anything to constrict that bronchial area because that bronchial area really hasn't been working on its own throughout the whole pregnancy. The lungs are not working good. So I don't want anything to constrict that. And it causes some neurotoxicity. And so those are the bad effects that can happen with our baby. Fentanyl, and I know everybody's thinking, oh my God, fentanyl, that's awful. That's what people are dying of. Yes, it is. But you have to remember that the majority of the time that we're given fentanyl is via epidural. So it's not going into the circulatory system. So when I give mom fentanyl, we don't normally give it IV. It can be given IV, but they don't want to because they know of the respiratory depression. And it doesn't last but about an hour. So we're not really given that IV or IM, even though your book talks about it. The majority of the time that we give fentanyl is via epidural. Okay, so with the epidural, we're going to talk about epidurals in just a little bit. So those are the side effects of that. So what do you think you want to have right there readily available when your mom's in labor and you gave her Stadol?
Narcan.
You can also, you've got the mom's dosage right there is 0.4 to 2, but you also have a neonatal dosage. And you better, as soon as you get that baby born, you better do what to him? So you'll know what the dosage is.
Weigh him.
You better weigh him because you cannot give. Are we supposed to know? The generic name of Demerol is fine. I just put them both. Technically, you got to have to know the generic name. That was the question. Oh, shoot. What did I just do? Okay. So you better get that weight because everybody, particularly the ones that have been through the pediatric simulation, know the importance of knowing that kilogram of that baby, right? Were y'all seeing when you were in labor and delivery, when they weighed the baby, that it came up in kilograms for you? Did y'all see that? I hope so. So you can weigh them in kilograms, but you better know it. You better know what those kilograms are. Nurses that are in labor and delivery have to know basic airway management. They also have to have their neonatal resuscitation certification. So they have to know, because of the commonness of us giving all the narcotics and knowing that they cause respiratory depression in a newborn, you've got to know how to resuscitate that baby. All right, so am I going too fast? I'm going fast, aren't I? I'm sorry. It's not the normal way I usually teach. Sorry. I'm just afraid I won't get through everything. All right, so regional anesthesia. That's what I was talking about with epidurals a while ago. Does everybody know what epidural is? Do I need to tell you what an epidural is?
No, I think we know.
Does anybody not know what an epidural is? Okay, good. Do you know what a spinal is? Do you know the difference in the epidurals and the spinal?
Epidural is they putting it in the epidural space.
Right. Does it go into the spinal column?
No.
No. Does it go in where they could paralyze someone?
I hope not, but probably.
No, because we're going into the epidural space.
Yeah, not the spinal. Okay, good.
Right. So, but the epidural where they administer that, the nerve endings to paralyze people are above the epidural space.
That's why they tell you don't move, don't move.
Right. Don't move, because I've got to get it exactly in the right area so it doesn't go into the spinal column. Can they miss? Absolutely. If a mom's not, good and still, can they get into the spine? Yes, they can. So it can happen. The other thing with when we put moms to sleep, when we put moms to have C-sections, they will get spinals. They will actually get spinals instead of an epidural. They want to make sure that they're numbing. An epidural, you're only supposed to numb from right underneath right where the xiphoid process is to right at the growing area below, right there on the knees. Before the growing. So spinals, they go all the way down to your feet. Okay, so I want to make sure that they're numb good. So there is a difference when we have a C-section, and I want them to have a spinal as opposed to having an epidural. All right, so epidurals got a lot of advantages. It's going to keep that mom very, very very comfortable because they can't feel. A lot of times they are numb to their toes. They don't need to be numb to their toes. They only need to be numbed to where they're going to be able to not feel when the baby comes out. The good thing is that she's going to maintain her airway with an epidural and that she's fully awake. So she can actually tell us when she's got more pressure or tell us when she needs to push. Okay, so that's the good thing of the epidural. So there's always bad things with epidurals too. One of the most common one is hypotension. What is the nursing intervention that you're going to do if you know that a mom is getting ready to have her epidural?
IV bolus.
Absolutely. How much? How much you want to bolus her with?
My nurse said to try to get the whole bag in, but they had to go with just half for my patient.
Yeah, 500 is our goal. 500 cc's is our goal. No, they do not do the question is, if you already have an epidural, and they need a C-section, do they do a spinal block too? No, they just change the amount of medication and the kinds of medications that they use. Yeah, so you don't have to get stuck again. No. So our goal is to get 500 cc's because we know that hypotension, and I'm talking 90/40. Okay, I'm talking a low blood pressure. So in order for us to prevent that from happening, because it's done prophylactically. So I know that this is a side effect. So I'm going to go ahead and bolus them 500 to 1,000 cc's. If my mom already has trouble with, for instance, like she's already broke her bag of water, then I'm going to be more insistent on getting that 1,000 in her, because I know she's probably a little bit drier in her circulatory system because she's lost all that fluid. So I'm going to push for 1,000 to get in her, but 500 is our goal. The other thing that happens with epidurals is mom, when they're numb, they don't know if they need to pee or not. And we just talked about just a little bit, if bladder distension, if that bladder is distended, that baby's not going to come down. So before mom gets the epidural, you bolus her with 500 cc's of fluid, and you make sure that she empties her bladder. And once they get the epidural in, you want to make sure that you are constantly checking her bladder to make sure that she's voided. That is a major, major importance, because they cannot feel that they need to pee. And we know that the bladder being distended is not going to let our baby come through or come down. That's what I just said. You have to make sure that when they're getting the epidural, you want to make sure that moms, you've assessed their pain level and the pain level after they get their epidural. You want to make sure their blood pressure, you've checked their blood pressure and their pulse, and you got to make sure that that baby has reassuring fetal monitor strip before. Because what you have to do is to get that mom in the position that mom's going to be sitting upright, and the baby's head is going to be pressing down on her cervix, which will maybe help her dilate a little bit more. But sometimes babies don't like that. So I need to make sure that I have reassuring fetal monitor strip before I let her get her epidural. If I have a not reassuring strip, then I'm not going to let her sit on that baby's head while she's getting the epidural. I've got to make sure that there's reassuring strip before I put her in that position. Okay, I just talked about that. Bolus 500 to 1,000 cc's. You know that you need to put an 18 gauge angiocath in a mama. Anytime there's at risk that they may have to go to surgery, you always want to put an 18 in, because why?
In case they need to receive blood products.
Absolutely. So you don't even start with a 20, you go straight to an 18. I've had to put a 16 in a mom before because she was bleeding. So go ahead and go to the straight to 18. Why do I keep repeating myself? Maybe because I want y'all to know that. We've got to keep monitoring the mom's vital signs until the block wears off. You can still assist that mom with the epidural in different positioning. So if you get that epidural on your mom and you've got the fetal monitor and baby's not liking what they're doing, what's going on, then you can still position that mom and have her sitting up, but don't get her out of the bed. After she gets her epidural, she's in the bed. You still need to reposition her, and you need to assess the ability of her be able to feel her legs. Okay. Don't get her up because you don't want her to fall. With an epidural, they can do it 2 ways. They can give you a one-time dose. Let's say a mom is 8 centimeters and she's insisting on getting a epidural. Well, they can give her, and she's maybe a first-time mom, then we know that she's going to have to push for a while. They may go ahead and give her the epidural because she is a first-time mom. They can put her on a continuous pump. So the medication is going there all the time. That is the most common that we're seeing that they're connecting her epidural up to. Now, you as a nurse have to monitor that epidural. You've got to see how much medication, because your mom is getting this medication on your clock. So you've got to keep up with what all you're administering to her throughout this whole time while she's in labor and while she's getting that continuous epidural. Like I said, one of the biggest things that is good with an epidural is that she's going to maintain her cough reflex. And do you know what I mean by that? Because most anesthesia, there are some anesthesia that can suppress what?
Airway.
Your airway, absolutely. So this one with an epidural, it's not going to. So it's pretty easy to administer that. Most physicians or most anesthesiologists are pretty good at it, and they do it very quickly. All right, do I have a chat here?
Miss Walker.
Yes.
So I've experienced both epidural and the spinal, and the spinal tap, when I had it by itself, it felt like it was up higher, like the numbness was up higher. So I actually got nauseous because of how much, it felt like I had a cinder block basically sitting on my chest, and I felt like I had to work harder to breathe. Yeah. Versus an epidural, it wasn't as bad.
Now, epidurals the medication can go up with them. And what happens is that the medication is going up too high. We want it, and that is the anesthesiologist's problem. And what he needs to do is know how to dose that mama. So he's not giving too much. Now, some moms the medication goes up and they have that feeling, I cannot breathe, because they're paralyzing your respiratory center. They're paralyzing all this up here. It happened to my daughter. When she had she couldn't breathe. She couldn't breathe. The key is, as a nurse, when you're assessing a patient who has either a spinal or an epidural, is that you don't want the numbness to go any higher than the nipple line. So when you're talking to her about where are you numb, if it starts going up higher than the nipples, then you better get some O2 on her, because she's going to start getting some respiratory depression. It'd be difficult.
Would we elevate them up in the bed a little more?
Yes. Yes. Okay. You can sit them up. The only thing is I can't put them all the way up. We can put them up a little bit because it can still go up.
So you don't want her in high Fowlers, but like between high Fowlers and semi.
Yes. Yes. Okay. And the other thing is maybe turn them to the side a little bit because they have trouble breathing. Yeah. You may have to do that. Now, if they're on a C-section table, then we can't put them in Fowlers or semi-Fowlers.
Yeah, she just jacked my oxygen up.
Yeah. Yeah.
And my blood pressure dropped really, really low too. It was like 70/40. It was really low.
Yeah.
And so
go ahead.
I had an epidural bolus too with my first baby, and he put it in the wrong spot. So when he went to inject it, it sounded like a train in my ears. Yeah, it was awful.
Yeah. And there are times that they're going to ask you certain questions. The anesthesiologist will ask you certain questions like, hear any ringing in your ears. That means that the medication's going the wrong way.
Yeah.
The other question is, do you taste a metallic taste in your mouth? If there's a metallic taste in your mouth, then that means the medication is probably not going where it needs to go. So there are some questions that that's the anesthesiologist's responsibility because he's administering that medication. Okay, so but we'll be the nurse sitting right there assessing it. All right, good questions. All right, or good comments. All right, so there is a difference than when we have to put our mama to sleep. Give me a situation where I have to put my mama all the way under. Now, epidural's anesthesia, but it's not general anesthesia.
A medical emergency.
When it's a medical, absolutely. So you would be seeing a lot of decelerations that are prolonged decels that we can't get them to respond by any of the interventions that we're doing. Baby's in trouble. We've got to get that baby out. And I mean out big time. I apologize if y'all are hearing the drilling, but if it's bothering you, I'm sorry. So we need to make sure that we see when did mom eat last. If we know that it's going to be a general, if she's going to, we need to know when she's going to eat. We also give her some type of antacid. Bicitra is one of the first things that they give, and that will help decrease the acid in her stomach if she did eat. The reason why I'm asking if she did eat, because I know she's going to be at higher risk for aspiration. At the point, if that baby is suffering, I don't care when she ate. I need to get that baby out. And if she, I just need to be aware that I need to have suctioning ready so she doesn't aspirate when I put her under. Okay. Another thing I want to tell you guys, and I don't think I've said this before, if you notice, I have placed wedge under right hip. After 28 weeks gestation, mom should never lay on her back. Okay, never lay on her back. After 28 weeks gestation, she should have her hip cocked to one side or the other. I don't care which one it is, just never lay. Because when she lays directly on her back, that fetus is going to lay on her vena cava and it's going to cut off her blood supply. So if it's, and the reason why I said put the wedge there is that my baby's already in trouble. So I need to get her off her back. When she goes to anesthesia, when she goes to sleep, I need that wedge underneath her because my baby's in trouble and I don't want anything else to impede. Mom is going to have to be really, really oxygenate her prior to her going to sleep because I got to give that baby as much, because when my mom is put to sleep under general, baby is put to sleep as well. I have 5 minutes to get that baby out. And that means cutting through the skin and cutting through the uterus. I got 5 minutes. So I want to oxygenate my mom. So when that baby gets a big old hunk of O2 before he's put to sleep, then hopefully that will last him or her long enough to get the baby out. It usually takes about 2 minutes for, once that mom is put to sleep, for that medication to get to the baby. So technically that baby's going to have 2 minutes that we can, so we put a lot of oxygen on mom and he gets a lot of oxygen, and in 2 minutes, I have 3 more minutes to get him out. Okay. If I don't, then my baby's going to have fetal depression. Any high risk fetuses are not, i.e. preterm babies, i.e. large babies. Any baby that's high risk, having a C-section via general anesthesia is not recommended, because I know my baby's going to be depressed anyway when he comes out, that I do not want to have mom. So I'm going to try to do it via epidural or spinal. So this is not the way to go unless it's an emergency. We don't ever want mamas to go to sleep if they're getting ready for their C-section. We do not want that. Not something we want. Here is that video or that slide I was telling you about different cultures, I've listened to those. I've listed those for you so you can see how some people in different cultures, that what you'll see out of them. So I've listed that for you. Okay, let's talk about premature rupture of membranes. Premature rupture of membranes happens prior to 37 weeks gestation. 5 minutes, Elaine. We got 5 minutes to get that baby out. And we know 2 minutes is going to, it'll take till the medication gets to the baby. I was just answering chat. Okay, premature rupture of membranes. Remember we talked about when they break, it's the barrier from the outside world. So they've broken, the mucus plug is gone and the bag of water is gone. We have to get that baby out within 24 hours. So once one of the things we have to do is make sure that it's the bag of water. Do you know when anybody seen in your OB experience what they test to make sure that it's the bag of water and not PP?
Isn't it the
nitrazine strips?
Nitrazine strips, absolutely. They're called nitrazine. So that tells me that once I place that and you open up the vaginal area and get the litmus paper inside, or the nitrazine paper inside the vagina and put it there, and what color does it turn?
Is it blue?
It turns blue if it's actually membranes. It will not turn blue with urine. So that is one of the things that we do to test to make sure that the membranes are ruptured. Okay. I've just listed the risk factors. Tobacco use is very, very common that would make the membranes rupture prematurely. Infection. So I need to be watching that mom's temp. So there's several reasons why we have that are risk factors for moms to have premature. The most common ones that we will see is hydramnios. Do you know what hydramnios is? Too much fluid. We also see this with multi-pregnancy, meaning if we have twins or triplets. If moms have UTIs, sometimes we can have moms that have had amniocentesis. And I know y'all talked about amniocentesis with Intrapartum. So that is one of the side effects of having amniocentesis done. It breaks your bag of water. And placenta previa and abruption. And we're going to talk about those two because those are very, very important things in pregnancy that we need to talk about. All right, there is a lot of trauma that can cause premature. Let's say they were in a wreck, that can cause it. Incompetent cervix, and I know that you talked about that in Intrapartum as well. And these are just other things that puts mom at risk for having premature. Premature rupture of membranes is greater than or less than 37 weeks, because 37 weeks, after 37 weeks is considered term. All right. So when they break, what are we worried about? The chorion and the amnion getting infected. And then the endometritis can also happen. It also puts my mom at risk for an abruption, and we're going to talk about that. And a lot of times moms don't want to come and get help when their membranes rupture because they're not sure. They think they PP'd. That's when moms are put more at risk for getting septic. Okay. All right. So remember, your nursing care for premature is the same. When we check TACO, monitor mom for infection, look at that fetal heart tone, don't go in and do vaginal exams if you don't have to. Okay. All right. So I have 12 o'clock. Actually, I have 12:06. Do y'all want to take just a 10-minute break? Y'all are not talking to me this morning. I look sleepy. It's that long break. All right, so I really want to talk about the previa, and I'm trying to find where it is. Is that where? Okay, that's where I want to be. All right, so I'm going to go here, and I'll get what, 10-minute break? Is that good enough?
Yes.
Okay, now I'm going to stop this.
Okay, so I'm just kind of like slightly confused. I just want a little clarification for it. So is it so much that the woman goes from like 1 centimeter dilated to like 10 quickly, or is it so much like her timing to the hospital?
Both. It both can. Like, for instance, I went from 2 to 10 in an hour and 15 minutes.
Oh, wow. Okay.
Mine was considered a precipitous delivery because I was there. That was with my first one.
Okay.
I was only there. It was my timing going to the hospital.
Okay.
I got there. I was 6. And I had a baby 45 minutes later. So it's both a combination of those.
Okay, sweet. Thank you.
Mm-hmm. All right, so let's go to placenta previa, because this is something that's very, very commonly tested on boards. So what this means is when moms get pregnant, the placenta is supposed to attach to the uterine wall at the top of the uterus. But what happens sometimes is that placenta implants in the lower part of the uterine wall. So what happens, remember, the cervix is at the bottom. Okay, so what it can do is it can cover the os of the cervix. There's several different types of placenta previa, and you can see it in this picture. The placenta is supposed to implant up here. Do you see where my cursor is?
Yes.
Okay, so this is where this placenta needs to be lying up here at the top of the uterus. It has implanted, and this is called a low-lying placenta. It is not all the way covering, because here is the os to the cervix right here. It's not all the way covering this os. So the baby can be delivered vaginally on a low-lying placenta. But mom is at risk for bleeding, because when the baby comes down, it could puncture this placenta and cause it to bleed out. Okay, so when they have a low-lying placenta, I can still deliver vaginally because it's not all the way covering the cervical os. The next one is a partial placenta previa. Do you see where the opening is here? And the placenta is coming and it's halfway covering the cervical os. This baby does not need to be delivered vaginally, because what can happen is that placenta can start coming out first. So anybody that has a partial placenta previa will need to have a C-section. They are at very, very high risk for hemorrhage. I don't want to put this mom at risk, because having a baby is already putting someone at risk for hemorrhage. With this placenta being partially, meaning it's partially covering the os of the cervix, I can't get that baby out safely without taking a chance of rupturing that placenta. So you've got the low lying and you've got the partial, and then you have a complete. So the placenta is all the way covering the vaginal vault, and it's all the way covering the cervical os. There is no way that this baby could ever come out like this. This mother is going to have a C-section. I just saw a chat and now I can't get to it. Who just chatted me with something?
It was me. I was just asking, just for like curiosity's sake, what is the exact medical reason why it's bad for a placenta to come out first? Is it because the baby wouldn't have oxygen?
Yes.
Okay.
Yes. It's going to cut off the blood supply to the baby, because if the placenta comes out first, the oxygen is coming from the implantation of the placenta to the uterine wall. Does that make sense?
Yeah, it makes sense. Thank you.
Yeah. So you cannot deliver this. I mean, this baby can never get its head through here first. So you have to have the fetus coming first, then the placenta. Because if that mama labors and she comes through here, she's going to bleed to death. And we cannot take a chance on letting that mama deliver. So partial, if it's low lying, it just means that it's lower down here. Partial means that half of it is the cervical os is covered in and up in a C-section, and complete will always be a C-section. Always, always. There's no way you can deliver that way. So moms that are at risk for this, moms that have had previous C-sections, moms that have a lot of gravity, meaning that they have lots of pregnancies, Asian descent, high gravity and parity, you know the difference between those two. Mamas that are older have a tendency to be more at risk for previous. If you've had previous miscarriages or abortions, or smoking cigarettes makes you higher at risk for this. And for some reason, our men like to, our little boy fetuses, like their placentas like to low down too. So that is the risk factors for moms. So the way that we're going to decide how we're going to prognose, what our prognosis is on this baby, depends on the extent of the previa. What I mean by that is, where is the placenta at? If it's low lying, I'm just going to watch it. If it's partial or complete, then I have to have my mama deliver C-section. We can watch that baby and see how he does on the monitor, but they're not going to let you deliver with a complete or a partial. If it's the partial, if it's covering the cervical os. Does that make sense?
Yes, it does.
Okay. All right. So when we have the previa, sometimes, let's say mom hasn't had any prenatal care, and they come in and they have all this bleeding, that the difference between the abruption and the previa, you have bright red bleeding, but there's no pain associated with it. Okay, so with the previa, you have bleeding, but you do not have any pain with it. Okay, most of the time it's a scant amount, particularly if it's low lying or if it's partial. You may have a scant amount. If it's a complete, your mom is more at risk for having lots more, the bleeding being more profuse. So there's going to be a lot usually when we have a low-lying placenta or a partial or a complete, particularly a complete, the baby's not going to be able to descend. The presenting part is not going to be able to be engaged because the placenta is in the way. So it's not going to be able, so when you do the vaginal exam, you're not going to be able to feel that baby's head to be able to assess what station that baby's at. And you can't be poking around in there. You can't be doing, I mean, if we know that there's a placenta previa, we don't do any vaginal exams. So if we have someone that comes in and we're not sure they're presenting with painless bleeding, and I do, before I do the ultrasound to know what's going on, I sometimes would do a vaginal exam. Vaginal exams are not good with previous, particularly if your mom has a complete previa. Do not do vaginal exams on them. Do not, because you're going to go in there and there's a possibility that you could rupture that placenta or tear that placenta up and cause profuse bleeding. So if a mom comes in and she tells you, and you look at the history and you find that she's got a previa, you know right off the bat you are not doing a vaginal exam. A lot of times, one of the first ways that we know that this baby, that if she hasn't had prenatal care, we know we don't know for sure she has a previa, is that baby is going to be transverse. You remember what that means? The baby's laying this way because the placenta is big and it's taking all that room where the os is, and it makes the baby lay transverse. When moms can sometimes start bleeding earlier in their pregnancy, and that may warrant the ultrasound to see about the placenta and where it lays. And if they are bleeding through their pregnancy with a previa, they will be put on bed rest. They do not want the moms up because we don't want that bleeding to occur. Or to continue. We got to stop that bleeding. We definitely got to see how babies are going to do. We've got to put them on the external monitor. We also need to make sure that they are type and cross-matched, because if that placenta detaches or if that baby's head's trying to come down, there is a chance that they can rupture that placenta. And I need to know what blood type they are, because they're going to need blood immediately if that placenta totally detaches and totally starts bleeding. I've got to watch that mom. If she's got active blood bleeding going on, she has got to be monitored with those vital signs every 5 minutes. And we've got to keep an eye. I really don't want her contracting. Okay, I don't want her contracting, because the more she contracts, the more chances that that placenta is going to rupture. So you may see sometimes that a mom comes in and she's in active labor and we see she's got a complete previa. You may see them giving her medications to stop her labor. Okay. All right. Any questions about previa? Low lying, partial, and complete. All right. Abruptio placentae is a very bad thing too that can happen. I was trying to say that nicely, but it couldn't be nicely. Abruptio means is when the actual placenta pulls away from the inner lining of the uterus. Okay. We don't know what makes this happen. The cause is unknown. Moms that are at risk is our older moms. If you've had a lot of babies, you delivered a lot of babies, and you smoked cigarettes, cocaine, trauma, car wreck, something like that. But the other thing is, this is another reason that we watch mamas so much when their blood pressure is high. when they have a preeclampsia, because we know that with that increased blood pressure, that can put more pressure on the placenta and cause it to detach. So that's another reason that I've got to watch that mama with her blood pressure. Can y'all hear me over that?
Yeah.
Okay, sorry. I know I'm loud, but I apologize. So we not only, if you know, I've told you through the whole time, you got to keep up with that mom, because this abruption can happen anytime during pregnancy or anytime during labor. Okay, if you've got these high risk factors here and that BP starts going up, then you're putting your mama at risk for having an abruption of that placenta. There are 3 types. You have a marginal, you have a central, and you have a complete. With the marginal, it's just barely pulling away. I think I got pictures. Yes. So I want you to be able to see here. Now, this is not a low-lying placenta here. This is a placenta that's good and high where it needs to be. Okay. So this doesn't have anything to do with the previa right now. This is a totally separate thing. This is marginal abruption. So the very, very bottom of this has become, do you see how it's all attached to the uterus right there? You see where my cursor?
Yes.
All that is attached. But this little part right here has now become detached from the wall of the uterus. So once it detaches, there is a lot of hemorrhage, a lot of blood that's going to come out. Okay. So that is our marginal one. This is a central. The thing that's different with central is that it usually is concealed. And what I mean by that, it usually stays inside the uterus. So we may not have but one little symptom, 1 or 2 little symptoms that even tells me that this mama has abrupted. And we'll talk about that in just a minute. I'm sure you're going to know or think about what might, or y'all tell me, what do you think might happen now? What would be the sign you think we might hear that mom tells me?
Pain.
Pain. Absolutely. There is pain there. Because remember, with the previa, there was no pain. With an abruption, there's pain. So this may be the one sign that mom comes in, because there's no way that I can see any vaginal bleeding, is there? It's all concealed inside the uterus. And so I can't see this blood happening. That's my dog. All right, so now see where that placenta has completely detached. Every bit of that has separated. Now, this is the very beginning. As soon as that separates right there, yes, the uterus can become very hard and large. That was the question. Can the uterus become larger? Yes, it will. Once the hemorrhaging starts, then the uterus is going to get hard and bigger. But right now, this is concealed. Okay. And what's going to happen, since it's completely, so what are you thinking? If this is completely separated here, what's happening to that baby?
He's getting squeezed or compressed.
He's getting squeezed, but what about perfusion?
Can't breathe. Decompression.
There is no oxygen supply. Where does he get the oxygen from? The placenta that's attached to the uterine wall.
So we have emergency C-section.
Emergency C-section. Absolutely. I have had one delivery that we saved both mama and baby. The mortality rate for a complete separation with this abruption, the mortality rate sometimes is 100%. So mama and baby both can die. So this is serious business. We have got to keep up. And the key to it is pain. And it's not where the contract. So where's the contractions going to be? The contractions are going to be in the fundus, right? And it's not going to be, that contraction is not going to be, the fundus is not going to be hard. Okay, because it's not a contraction. It's a pain from that placenta being detached from the uterine wall. Okay, like I said, there is a high, I got low incident of fetal death, high incident if it's a complete. And it does depend on the degree of the separation. If I have a marginal, then my baby should be fine. Okay, but if I have a complete, the mortality rate is very, very high. All right, so I've got to watch the contractions, and I've got to watch the measurements of the, this is what Elaine was talking about. You are going to see as the concealed bleeding is occurring in the uterus, the abdomen is going to get larger. Okay, it's going to get larger. So moms, like I said, this is a life-threatening situation. Mama can bleed to death. You're going to have to give her, blood because she's going to lose a lot of blood. Cesarean is definitely the best way to go to get this baby out. And most of the time, the fetus is born dead. So yes, it's not, but the key to it is pain. They're going to have pain with each one, with this abruption. The other thing that you've got to watch is, and the reason why I put this one here is Pitocin. Remember we talked about our bodies normally secrete Pitocin, and that makes the uterus contract. When I either augment with Pitocin or induce with Pitocin, you have a contraction of your own body, and then you have another contraction. So we have contractions that are going very, very strong and doubling up on us. So moms that are being induced and being augmented are at higher risk for abruption of their placenta. Those increased contractions are making that uterus overwork. That uterus is going to get agitated in there because it's doing so much, and it's going to have a tendency to pull that placenta away from the uterine wall. So it's pretty, you've got to watch these moms when you're giving Pitocin. Okay, any questions about the previa or the abruption? You've got to know about those two. Does anybody have a question about those? I know why y'all are so sleepy, because it's raining.
Yep.
Y'all are sleepy. You've been resting the whole time, and y'all are not talking to me this morning, because I know I'm going real quick. All right, the next one that we need to talk about is dystocia. This just means that the uterine contraction pattern is not doing the job. It is dysfunctional or a difficult labor. There's not any rhyme or reason to why this happens. Just some moms don't. We want to make sure we hear all we need to know. Oh, I don't usually say that. You need to know this. This is also called, so the whole goal of labor is to have contractions to change that cervix. This means these are the ones that you hear, oh, I was in labor for 48 hours because they had a dysfunctional or a dystocia labor, meaning that their contractions were not changing their cervix. It's not able to dilate. It's not having any effacement there. It's just taking forever to do what it needs to do. And one of the main things is that the contractions don't build in their strength and their intensity. So if they don't build in their intensity, there's no way they can dilate that cervix. What happens with these moms is they just get exhausted. They cannot get comfortable. And there again, if that contractions are happening, but they're not effective enough, then they're putting your mom at risk for that separation of that placenta or that abruption of that placenta. If the membranes are ruptured, then that's putting that mom more at risk for infection. So when you hear someone that has been laboring for 24 hours and not making a lot of progress, and you know that they've got all these problems with, they're exhausted, they can't go on. They can't do what they need to do. And then there again, our babies start saying, you know what, I don't really like my environment around here. So my baby's going to start showing me signs like late decelerations. Or if the baby comes out, he's either going to have a cephalohematoma or some caput or some molding because he's just being slammed up against that cervix and it's not giving him any leeway. It's not moving out of the way so he can get down through the birth canal. So dystocia is very hard on mom and very hard on baby. One of the things that you can do is help her relax, put her in the shower, put her in the bathtub. I put tab baths, meant to be tub butt baths. Sorry. Do a lot of relaxation techniques, therapeutic touch. One of the things that I always encourage, keep those linens, and we talked about that just a little bit ago, keep those linens changed, keep her mouth dry or washed out, let her brush her teeth because she knows she can't eat. So just give her some ice chips. And what other treatments are we going to occur? We need to start talking to her about maybe the possibility of a C-section. Particularly if these moms come in and they have this birth plan and say, I'm not having a C-section, I'm not having a C-section. We got to start talking to her about the possibilities of having a C-section. And one of the main the other thing that can occur, this one is the dystocia, but hypotonic labor patterns. That's when we contract and we contract and we contract, and they're just not getting strong enough. Their intensity is not getting strong enough to do what it needs to be done. These are the ones that you're going to see that they're going to have to be, the first thing that they're going to do is they're going to break their water. That is, and remember when we break their water, what do they have to be as far as dilatation?
Centimeters.
You have to be 2 centimeters before they can break their water. So hopefully with a hypotonic labor pattern, they've had enough contractions to change them to 2. So if they are not 2 centimeters, they cannot break their water. But another thing that we can do is stimulate their nipples. We've got to improve the quality of their contractions. Their contractions are not doing the job. Stimulations of nipples will stimulate oxytocin in their own body, and that will assist in the contraction. So we'll try anything that we can do to get this baby delivered. I've given you a picture of what hypotonic contractions look like. You can see that they're just not looking and doing the trick. This is what on the top one, that's what I want to see happen. I want it to go up and down and have some rest tone, and up and down and have some rest tone. This right here, this one looks like a good pattern, but it's not. What is it not having a lot of? Right here.
Rest period.
Rest.
Not having a lot of rest period there. So that contractions are getting overstimulated, but they're not effective enough to change the cervix. And this right here on the bottom, that's what you call hypotonic contractions, not doing anything to get that cervix dilated. We talked a little bit about presentations. We talked about breech. Breech means that there is the presenting part is not the head. It's either the shoulder or the hiney or the legs. This puts mom at risk, particularly if it's a first-time mom. And I think we've talked about that, right? First-time mom, breech presentation, got to have a C-section.
Yes.
Okay, so I'm not going to talk about that. I did put a little picture here of the different types of breech. You don't necessarily have to know the frank breech or the incomplete, but know that they're breech. And know the biggest thing that know that the presentation is not vertex. Okay. All right. Prolapse cord. This one's pretty important. This is also a medical emergency. Anytime you have a laboring patient, you have to do, when you look at the vaginal area, you have to be looking for the cord first, because it can slip out very easily sometimes. But remember that if the placenta is up at the top, then the cord should be out of the way. Okay. But when you have a prolapsed cord, the cord, which means, and I'm going to show you this picture, is that the cord comes out prior to the baby. So what happens is the baby could lay on that cord and compress it. So when it compresses it, what's happening?
It's cutting the circulation off.
Is cutting their circulation off, so that baby is becoming hypoxic. That baby is no longer getting any O2. Okay, so what you need to do, if this is an emergency. I am so sorry, y'all. I'm gonna move this little lady over so y'all can see what this other says. Woo, I'm gonna move her there. The first thing that you're gonna do is put mom in the knee chest position. And I mean, put that head down and get that bottom up. And the reason why you're doing that is that you're pulling that baby off the cord. Do you see how the baby's coming down away from the cord? And you will need to put a sterile glove on and put your hand in that mom's vagina and keep that baby off the cord. And you will stay with your hand in her vagina until you get up to the C-section or get to the C-section room and deliver that baby. And that baby's got to be born by C-section. You put her in the knee chest and you put your hand and you are pushing that baby off the cord so we can maintain perfusion of that baby. That is so important. This is a medical emergency, and that mom's going for an emergency C-section. Okay. And then I put CPD on here. I think that y'all talked about that in Intrapartum a little bit, but I wanted to let you know that you will see CPD a lot, which is cephalopelvic disproportion, which means that the baby's head is too big to come through the mom's pelvis. One of the things that you will hear nurses say is if a mom is in labor and you have done everything that you could possibly do for her, you have done position changes, you've had her on the ball, you've had her on turning the positions, and you've done everything that you could possibly do, that in that presenting part is not engaged. Sometimes nurses say that is failure to progress. I don't want to hear you say anything to anybody using the word failure. That is a very negative term. And I don't, because mama might not hear to progress. All she's going to hear is failure. And we are not failing at laboring. I don't care if we have to have a C-section. This is not a failure. The whole goal of getting mama's laboring is to get a healthy baby and a healthy mama. And if it comes up to be a C-section, then it comes up to be a C-section and we have a happy baby and a happy mama. But this is what patients see a lot, particularly in the younger patients that are very, very skinny and very, very, they're tiny, and the type of pelvis they have just is not going to be able to deliver that way. So we're not going to be able to deliver that way. Please don't say failure to progress for your mama. All right. So we always think that labor and delivery is such a happy place. Well, the majority of the time it is. But you also have to realize that there are some very sad things that happen too in labor and delivery. My best friend went through 7 years of infertility. 7 years that we called it them going to the Love Shack in Charlotte. So they would go to the Love Shack, get their specimen. I would pick her up, take her to the doctor, and they would artificially inseminate the sperm. So she got pregnant with a set of twins. At almost 21 weeks, she went into labor and she had both babies and they both died. So it's not always a good thing. It's not always a happy place down there. Is that you have got to understand that you're going to have to learn how to deal. It's just like when you have a patient that you've taken care of that's passed away. It's hard to deal with moms. One of the biggest things that I would highly suggest for you is to encourage your patient to be involved with a group that helps them deal with their grief and their bereavement. So that's a very, very hard situation that you're gonna have to deal with. You also may see that moms come in and there's no heart rate. So mom's gonna have to go through delivery knowing that this baby is not alive. So you've really got to take that in consideration and get the community services. I'm so sorry, y'all. I know y'all can hear that. You've got to reach out. We can't do this all. We've got to get whatever sites of services are available out there. We've got to get that mama and that daddy involved. And I know my best friend went to a support group for a long, long time after she lost the babies. So we've got to get them. One of the biggest things that you got to she labored. You've got to take care of her just like you take care of every postpartum mom. And one of the biggest things is please keep that once that mom's been discharged from the labor and delivery area and you take her to the postpartum, please don't put her in a room that's right there with other moms having their babies. Get them away from all the laboring patients and all that, because that's just going to add to their grief. So that is a very difficult thing to deal with. So I hate ending on this, but there is the bad side to this as well. So that is all I cannot believe that I finished with 5 minutes. So what questions do you have of me? None? We have talked about everything that is on your test. If you have any questions, you can email me anytime. Yes, does someone have a question? All of y'all got your thing. Okay, what kind of quick review do you want me to do? Somebody just asked to do a quick review.
Oh no, maybe you can go over the 50 questions on the test.
Oh, sure. I'll be right on that.
In no particular order.
Okay, are there medication questions? Do you mean medication calculations?
Yes.
There
So
are
like the same 5 that we've been doing the whole semester.
Yes.
Okay, thanks.
I did not put any calculations like with Pitocin.
Okay.
You know, because the protocol is so different at different hospitals. So I'm not going to be requiring you to understand the Pitocin. Just know what the Pitocin is and why you give it.
Yeah.
Yeah, but the same calculations that you've been doing. And I'm having
to be.
Go ahead.
Do we need to be able to look at a fetal monitoring strip and be able to tell like what's going on just by looking at it?
That's what I've been trying to do, but I cannot find any that doesn't have what it is on it, like a strip that it has early decelerations written on it. It's more of a description. So you may say, you know, this is going on, this is going on. What do you think the strip is? So I've been trying to find those, but I haven't been able to find any.
So basically what you're saying is the mom just finished a contraction and the baby's heart rate dropped to 110.
Yes.
Or 105.
Yes.
What interventions would you do?
Yes.
Okay.
Yes. That's all. That's application. That's what I want to see you doing. And if you look at that, I don't know if y'all ever look at the objectives for at the beginning of in the syllabus, there is a competency handout at the bottom of the syllabus, and it goes through all of the objectives. So I have met every one of these objectives on these things. So if you want to go through there, that's a good outline.
Like this, Miss Walker. Hold on, let me turn my camera on. I do like practice questions. I don't know if you can see it very well. But like it says, the nurse is interpreting the fetal monitor tracing below, which of the following actions should the nurse take at this time? And then,
absolutely. That's what I want to know.
Okay.
Yes.
And then my other question is like, well, we have questions like this. Which of the following pictures depicts a fetus in the ROP position? Or should we just be able to describe it?
I'm going to be able to describe it. I have not been able to find the pictures that I want. Now, I've got 5 more questions to do, so I may find.
I found these on Amazon, not on Amazon. Good Lord, on Google.
Well, see, I don't want to do Google. I don't like to do Google because everybody has access to that.
Yeah.
So, yeah, I mean, I could make my own up. Yes. But yes, and it's all about, you know, like I've said before, this is a pretty straightforward unit. It is what it is. You need to know the definitions, what's happening with the mom in the first stage of labor, what's the dilatation, what's the effacement, how do I know that she's in the latent phase, how do I know she's in the active phase, how do I know she's in transition, based on your assessment skills and the data that you gathered.
Okay.
And yes, you are going to have to know the position, but
Like the
it's
cardinal
not hard.
movements.
It's not hard. Yes, you've got to know those cardinal movements.
Yeah. Okay.
Boards is going to ask you about that. Yes. This is probably the least hardest test I've ever given.
That makes me feel good because
Well, the
I
thing
do
of
really
it
good on
is-
your exams.
Yeah, I mean, I talk about everything that I want you to know, that it's important based on what the boards is wanting you to know. I don't teach to the test because I don't say you need to know this, but I did today. But I look at what boards is wanting you to know. This is a specialty area. These are the things that even if you take boards tomorrow or in a month, you'll be able to answer it because it's this more basic.
Mm-hmm.
And it is what it is, like signs of labor and how do you know what the first stage of labor is and how do you know what the second stage of labor is. So, all right, any more questions of me?
For the cultural considerations, do we just need to, I guess, basically just study the chart that you posted in the...
Yeah, the ones that I talked about or I posted are straight out of your book.
Okay.
Yeah.
Okay, that was my last question.
What was that question that she had?
About culture, different cultures and stuff.
How they react in labor.
How they react in labor.
Oh,
what
culture, like
Culture.
Spanish, African, like that.
Yes.
I'm like,
if you read for those different cultures and things that they do, like some cultures, you can't talk. The patient can't talk in labor.
Yeah.
Like the Chinese women, they won't verbalize their pain.
Right.
Mm-hmm.
Yes, they will not.
Do you have to like constantly ask them if they're in pain?
Yes.
Because they won't verbalize it.
Mm-hmm. Yeah, so it's, I mean, that's the ones that I put on that. I would study those.
Okay.
All right, any more questions of me? All right, I will turn this little recording thing off. And then I'm so good with that recording thing. And now I can't figure out what I need to do. All right, come on, help me. Okay. All right, so now I will post that for you guys. And y'all have now completed You Will Never Have Me Again. So I wish y'all the best of luck on Wednesday, and you'll never have me as instructor again. Aren't y'all glad? Yay! I survived the law. I survived the law. All right, y'all crazy people. Go get some studying done, and I will see y'all on Wednesday. I'll send out the invites, and whoever's proctoring, you will send out the invites. All right, bye.